Mr. W is an 80-year-old male who presents to the emergency room from a long-term care facility complaining of respiratory distress for 6 hours. Upon assessment, he was noted to have an established tracheostomy, coarse lung sounds, and pulses noted at the radial site. Focused assessment revealed the patient to have symmetrical chest movement, intercostal retractions, major abdominal movement with respirations. EMS administered 3 albuterol treatments via nebulizer and 125 milligrams of solumedrol via the patient's established PICC line prior to the arrival of the ER. Vital signs are as follows: blood pressure 102/58, heart rate of 118, sinus tach, 30 respirations, and 102 axillary temperature. 12 lead EKG showed sinus tachycardia.
The nurse utilized the patient's PICC line and initiated normal saline at 300 mL per hour per provider's order. Chest X-ray revealed the patient had pneumonia consistent with possible aspiration. Patient was admitted to ICU. Care plans included broad-spectrum antibiotic coverage after blood cultures were obtained per pneumonia core measures. Patient was also placed on ventilator support via the patient's established tracheostomy, and tracheostomy care was performed every 4 hours as a part of the VAP bundle. Patient was also receiving feedings via his established PEG tube.
The highlighted skills include tracheostomy care for ventilator support. EMS gave solumedrol on arrival via PICC line route. PEG tube with intermittent tube feedings in the ICU. And the core measures include ventilator-associated pneumonia, VAP, with evidence-based practice of mouth care and tracheostomy care every 4 hours with chlorhexidine. Pneumonia core measures include broad-spectrum antibiotics, post-blood cultures.
Mr. G is a 40-year-old male who was brought to the hospital from home by EMS reporting chest pain, shortness of breath, pain scale stated 10 out of 10, and patient states, "I am going to die," about 30 minutes ago. EMS gave 325 milligrams of aspirin, 0.4 milligrams of nitro sublingual in 3 increments, and initiated 2 liters of oxygen via nasal cannula. In the emergency department, the patient's vital signs were the following: blood pressure 155/85, heart rate 115, respirations 30, and temperature of 98.4. The nurse performed an EKG which revealed an ST elevation. The nurse then started an 18-gauge IV in the left forearm and gave 4 milligrams of morphine, TPA, and started on a drip of heparin at 1,000 units per hour per provider's orders.
Mr. G was transported to the cath lab for a cardiac catheterization that revealed 100% blockage and was sent to surgery to begin emergent coronary artery bypass graft. Patient returned to PACU with a chest tube placed on his left side. On assessment, the patient's vital signs were a blood pressure of 85/48, heart rate of 120, respirations of 28, 100.4 degrees Fahrenheit temperature, and was noted to have a distended abdomen. An ultrasound was done at bedside that revealed GI bleeding. The provider was made aware and ordered a NG tube placement stat with continuous suctioning. Patient was immediately transferred to ICU.
The highlighted skills include an 18-gauge IV placed as standard for access, heparin calculation, chest tube inserted post-cardiac surgery to ensure fluid and air is drained, NG tube, which is verified by placement of X-ray, and the core measure is the AMI core measure, which includes an aspirin, statin, ACE, ARB, beta blocker prescribed at discharge, a fibrolytic therapy received within 30 minutes of hospital arrival, and a PCI within 90 minutes of hospital arrival.